record on this. All right, I've just been going back over that paper that you wrote. It is ludicrous. And well, I'll share something with you. I was just chatting with Asim Malhotra the other day. And Asim published his first paper about 7 or 8 years ago, kind of arguing against statins and arguing against the cardiovascular disease, and got huge pushback from the journals and everything. I think that the same thing has happened with you, where science is solid, but the politics won't allow them to change their way of thinking, at least not yet.
That's right. That's right.
So
it's really funny because a lot of the biologic and basic science literature really does, from what we take all this information, supports this. And I tell my husband all the time, and he's like, how come you guys aren't talking about this? And I'm like, the clinicians are just too busy.
Well, it's not also too busy, but when you are working with medication and medication prescription, and time is money,
it's
possible to sit down and talk to patients about changes they need to make in terms of behavior. It takes long to do that.
Oh, yes. And medications and surgery in my field work so well that sometimes, I mean, and there's such an emergent situation oftentimes with women who are bleeding heavily and blood transfusions, and they just want relief. And so I totally get it. But the big thing is that when patients come to really request and understand why they're having problems with gynecologic disease, a lot of gynecologists will just say, oh, it's related to your genes, or you have cysts or whatever, and it doesn't really help connect the dots about what brought women there. And once you teach them that, it's easy, and then they get to decide how they want to be treated, and with lifestyle, medication, surgery, it's pretty straightforward. And then there's such a great relationship after that develops, you probably know, because then you hit all of the lifestyle factors that really bring women and men to where they are, so.
But gynecologists, probably more so than almost any other specialty, have a duality. Yes, there's a huge therapeutic component where there's a problem and you fix it with surgery or medications, but you also have a phenomenal interaction with women from menarche forward.
That's right.
As an early preventative. Most of us with surgery and the type of stuff we do is therapeutic. But you have that opportunity as a gynecologist to interact with even young people in a preventive way.
Oh, yes.
And that is where I would look at this, not just in the therapeutic side, but on the prevention side, as being a wonderful opportunity to prevent not only gynecologic disease, but cardiovascular disease going back the other way.
Well, that's exactly how I frame it, is because the Well Woman exam is really the doctor's opportunity to see what is the menstrual cycle doing, and the menstrual cycle is a vital sign. And so you can tell hyperinsulinemia, endothelial inflammation from those two things if you can tell me if it's regular and light, And most of the people right now are on birth control or hormonal therapies where it masks what's really happening. And not to say that birth control doesn't have a role, it absolutely does. However, in the modern day, it's really limited the gynecologist's ability to really define what's happening metabolically. And that's where I like to take it just to the very beginning. What's your menstrual cycle like? Is it 3 to 5 days? Is it, a few pads a day? I mean, really every month. And that's what it should be. But right now I'm going to be doing a video on like the concept of like period underwear, which to me is really crazy, because have we really gone to that level where you have to be wearing a diaper overnight because you're bleeding so much? That's just, and then of course, the companies have really gone on to that.
Right. So they designed trendy, I mean, it's like urinary incontinence, which is a piece of this as well. So, which is a consequence of taking out that uterus on everybody. But let me ask you this. So, what I want to do is let me pump the brakes here, because there are, and I may even start with that as a preamble as we get into this. But let me just ask you a couple of questions to start with. It's Andrea Salcedo, is that right? Or is that, am I saying it correctly?
Salcedo,
Salcedo, okay. And are there anything specific in you're at Loma University?
That's right.
Okay, and you are an associate, an assistant, what?
Assistant professor.
Okay.
If this article gets published, I'll finally get associate status.
Good. Is that what you want to do? Are you into the academic side, or do you prefer to be on the clinical side or the academic side?
I like both. I do really like both. I think that in order to really impact change, I do have to publish a little in the academic setting, just to kind of keep a lot of the credibility within my in my university. But also I have to do a lot of clinical. I have to do YouTube. I have to do all those things to really reach the granular audience so that they can actually push the needle, because it's really the population that pushes the needle.
Sure it does. And the other question is, as a academic gynecologist, are you kind of three parts to this? Are you primarily operative gynecology? Are you office-based gynecology, medications and testing, or are you, and what percentage is OB?
I do all of it. So I do probably 30, 30, 30, and then some research on the side. And so, you know, I'm in the OR doing hysterectomies. I'm, you know, delivering babies, and, you know, where I work, we deliver and take care of the sickest women in the state. And so I'm surgically very strong because what I handle in terms of the obstetrical, you know, disasters that come through a lot of times. And then I have a really big office-based practice. And I think there's been so much interest in what I'm doing. It's really kind of shifting towards the office, because
that's the question is, you know, when you're operating on someone, it's too late.
That's right. That's right.
What you do operatively is very destructive, and I don't mean that in a nasty way.
Oh, yes, no,
but it's often an irrevocable destruction of a woman's uterus, whereas what you do in the office can potentially have a preventive bent to it. And it'll be interesting if you don't mind us also talking about some of the obstetric stuff, particularly the way we manage patients and the whole gestational diabetes, PCOS side of things. So we can go down that pathway. Just before we go, so is there anything in the preamble in terms of your background that you want us to know? I'm going to ask you to tell us a bit about how you got to this point, and you can recount your academic history. I tend to try to keep that fairly short because everybody's got this long list, and I think
everyone's got this story.
Yeah, what's the story? And then where your personal interest in this avenue, was it just you stumbled on it professionally? Was there a personal story to it? But the other key thing, and we just actually had this earlier this week, is and really is one little thing I wanted. First of all, how's your time? Are you okay with time?
Yes. So I think we have to conclude maybe a little after the hour.
Okay.
So that's when my kids will run in at that time.
Okay.
So
okay, because there's so much to talk about, and even if it's in two parts, that's fine. But one question: how do you find working in a blue zone?
Yes. So I think the blue zone concept is really exciting because it's multifaceted and not just dietary approach, because what we know about lifestyle factors and their impact, it's community, it's faith, you know, it's a sense of belonging, and then of course dietary factors also. And so Loma Linda City has all of those things, mostly though in the framework of the Seventh-day Adventist setting. And so while I'm not Seventh-day Adventist and I just happen to work at Loma Linda University, I do think there's like a strong sense of community, and that really does play a role in the outcomes. Now, we are probably seeing a little bit less of, like, you know, the centenarians that we used to see, and I'm wondering what that's going to look like with the newer generation of folks that are from the blue zone. But yeah, I mean, we've read the books, and we, you know, I know all about them and stuff, and so I think there's a lot to be emulated, and it really just depends, because precision medicine is really important. Where, you know, I'm Mexican American, like, if, you know, we Mexican Americans are the most plant-based people out there. We eat beans, rice, tortilla all day, and yet we have the biggest chronic disease burden in this side of the West Coast. And so well, I think that plant-based diets really work for some people if that's going to be the way that they avoid processed food. But for certain communities, it doesn't work. So.
And is there any conflict in, when you think of a low carbohydrate diet, it's very easy to confuse that or cross over to the ketogenic, even carnivore or omnicarnivore eating pattern. Is there a conflict if you recommend that at your university or in your
No, because I really try to run with the science, and I think that you can't really argue insulin resistance particularly in gynecology. Like you can't move away from that. I mean, so once I really frame what I'm doing based on the science, then it's very easy to accept. Now, who knows what's going to happen? However, I do run several programs. I have what's called a group called Conscious Motherhood, which is an inter-pregnancy care program that for women who had cardiovascular disease and obstetrical complications during their pregnancy, they come and see me to help reduce those risks. And I definitely base it on an insulin resistance model. And then, right now, I mean, these women just with 8 weeks with me are, losing 20 pounds, deprescribing blood pressure medicines and stuff. And so that when they have their pregnancies in the future, they are not, plagued by heart disease or future complications related to pregnancy. And so it's really exciting. And they know what I'm doing. And I think like that's really exciting also. But you can't ignore the origins of where university is and where it came from. But on the other hand, when it really comes down to it, it's all about health, right? And what health looks like for different people and the different ethnic groups and cultures that are in front of you. And you have to make it precision medicine based on what the needs are of those particular people. And I think we can all agree that everybody needs to eat less sugar and reduce their processed food intake. And when it comes down to it, that's kind of what we're saying. So
right. The other question I have is, are you trained in lifestyle medicine?
No, I'm not. Mm-hmm.
So that's not a prerequisite?
No. Mm-mm.
Okay, it's interesting because we were talking just this past week to a big Blue Zone facility in Miami, a preventive facility. And their requirement is that you are trained in lifestyle medicine.
That's right.
To function and practice there. So that's why I asked that question. Okay, so because the other piece of it, I understand not eating carbohydrates, but particularly when it comes to the OB and as a pediatric surgeon, brain development in the child primarily, that does require a higher fat consumption, and navigating around those sources of fat in a non-meat-based advocacy program, it can be a bit of a challenge.
It is, and I think there's a lot of different ways to look at it, and I think that no one would also argue the role of 3-omega fatty acid, and where do you get that from? Well, salmon and a lot of our fishes and stuff, and so I think that's really important. And I've never heard of anyone saying like, no, don't eat that, don't eat salmon because we don't want you to eat meat. And that's not the message that's being conveyed, and so DHA is really, really important. And so particularly with what I do. And so, oftentimes, if we also know that, salmon and some fish can be very cost prohibitive for some folks too, and it's particularly in the under-resourced settings that I work in. And so, we're constantly prescribing prenatal vitamin with DHA for those reasons. But the message is not don't eat meat. It's, because, and then you're going to have struggles with DHA, but it's more of how do we improve your nutrients? And one way to do that is with salmon.
Sure. No, absolutely. And okay, so let's, I may cut and splice some of that into, because those are all the things that I'm passionate about from the pediatric side, but let's go ahead and start this. So let's see.
Rob, is your practice mostly surgical, or are you doing more clinic now?
No, I've since COVID, I've switched across. I miss the surgery tremendously. I still do a fair amount of surgery, but I'm probably about 60-70% now office-based. I'm a lot older than you. I'm in the back end of my career, but I still operate, but it's all elective. I don't take call, which is a wonderful thing. And then because of my interest in the metabolic space, I've shifted very heavily toward doing that and less
Yes.
surgery.
Don't you feel like you can impact more people that way? I don't know. I just feel like a tough surgery can last 6-7 hours, and there goes your day.
I mean, I like you. I love the surgery. My home is the OR. That's where I'm most relaxed. That's where I have the most fun. That's where I'm really good. But the metabolic message is also true. But I think as an exit strategy for me over the next decade of my life, which is my exit strat, the more I spend in the office, the more longevity I have. And
oh, absolutely. I'm very similar because we take OB call, and I can't taking 24-hour call for the rest of my life it's an exit strategies in place.
Exactly right. So we'll talk about, but the two of us are kind of crossing over in our careers.
That's right.
So hi, this is Dr. Rob CYWES. I am the Carb Addiction Doc. Today we have the absolute pleasure to welcome Dr. Andrea Salcedo to this audience. And Dr. Salcedo is based in Loma, Linda. She's an academic gynecologist, obstetric gynecologist, who I met several years ago. And it's just been, I'm doing a bit of a Katy Perry right now. I'm getting goosebumps over here at just even introducing you. Can you tell us who you are, what your story is, how you came into this? And then we're going to do a deep dive into some of the gynecologic obstetric aspects of a low carbohydrate lifestyle.
Yes, thanks so much. So I am the conscious gynecologist. I'm Andrea Salcedo, and I definitely have walked this path with you also as a guide. But what has brought me to where I am, I've been practicing OBGYN for over 15 years now. And I had my first child, 12 years ago. And with my final son, I ended up having gestational diabetes. And I was evaluated with that glucose test that we always do. And the 1 hour glucola for me was 197. And I was 120 pounds, and I looked the way I do now. And my colleagues were like, how the heck did you get gestational diabetes? And I didn't even have to do the 3 hour test. Like, I didn't even do it. I knew. And, but it was kind of doing what everything else was doing, whole grains, a little bit of meat, a little bit of fat and stuff, and working out. And it was very, very shocking. But so as I started taking a dive into what gestational diabetes looks like and the rubrics involved, and I actually probably was a good thing. The dietitians thought I was such an expert at diabetes. They didn't even have me go through the class. And as I was looking at what the recommendations are, 30 to 50 grams of carbs per meal, I couldn't handle it. I any little carb, my sugars were off the chart. And I was like, no way, And so towards probably against the advice of many people, I was lowering my carbs during the pregnancy because I just couldn't eat any, or else my sugars were above 150. So I knew that there was something not right, because even the plant-based like quinoa carbs and beans and in rice that are very prominent in my culture were not things that were helpful to me in my pregnancy. And so I nearly became carnivore, not really because I knew what the word was, but because I was just paring down, and I felt great. And I gained probably 15 pounds. My son was 6.5 pounds. He slid right out. It was the easiest delivery. But during the postpartum period, I took several months off to really try to figure out, what does nutrition look like for women? And I started taking nutrition network classes and looking at all the end organ damage that we learn about on all the other hearts, lungs, liver, kidneys. I thought, wait a minute, how come we're not talking about the uterus? And the uterus, and also the ovaries, but most prominently the uterus, is an end organ too. And it's basically able to receive the same endothelial inflammation that every other organ does. And it's actually one big smooth muscle. It's one big blood vessel. And so if anything is going to go wrong, it's from the uterus. And so, from cardiovascular disease, risk factors that turn into obstetrical complications, to gynecologic disorders. It was such a A+B=C moment for me, and it really just took off. And so I started doing research and looking at the data, and then I sent you your email about, are you thinking about this? I'm noticing fibroids in people who are diobesogenic, and I'm noticing endometrial cancer in people who are obesogenic. Like, what's the connection to help me connect these dots, you know, and that's when really things just started opening up for me. So thank you so much.
No, listen, it's been a wonderful journey to watch. So let me ask you just a personal question then. Eating that way, did your gestational diabetes get better?
Oh yes, it did. It absolutely did. And it was a diet that I continued because I felt so good after, and my skin cleared up. I started not getting these weird rashes, and I really kind of thinned out even more. And I was pretty thin, but I became more lean, you know, and oh yeah. So, you know, there's a lot of evidence for what we're doing, and to kind of approach obstetrics and gynecology this way. And so really my passion is to try to help convey the message from the science perspective that's already existing and coming out.
Perfect. So let's start with this. I appreciate that sentiment. And as you mentioned earlier on, you're moving for upward in the academic stream. And you've recently, I had the honor of you sharing with me a manuscript that you've written, which is absolutely phenomenal. The title that I have here is Therapeutic Carbohydrate Restriction as a Metabolic Modality for Prevention and Treatment of Abnormal Uterine Bleeding. And I know that's a big mouthful, and I really want to dumb this down to lay people, but what is said in the paper, and I think there's certainly a truth to this, is that abnormal uterine bleeding, not aberrations with the normal cyclical bleeding in women, is the commonest reason for gynecologic consultation apart from birth control in America, with a massive annual cost. And you looked into this from a causal perspective. I know when I was going through medical school, it was called dysfunctional uterine bleeding. It has since been literally fleshed out. It's been called abnormal uterine bleeding. There's now several categories that encompass this. And while a lot of women may not know the exact terminology, pretty much everybody is going to have, and it's a sad statement that I'm making now, every woman is going to probably have some form of the dysfunctions that or have encountered some of these dysfunctions in their life as a woman going through menstruation, from the age of menarche all the way through to menopause and beyond. Starting out, could you just explain to me, or explain to the audience, what abnormal uterine bleeding is, what it entails, how it's classified, and if we can keep it as lay as possible? I know you interface with patients all the time, but if you're able to help us to understand what it is before we go into a dive of what the causes are and how we've changed that thought process, can you tell us what that set of problems are? I'm not going to call them a disease, but they're problems that women encounter.
Yeah, they're dysfunctions, you know, and so absolutely. And the abnormal uterine bleeding is the term for any bleeding that is not a monthly regular light period from puberty to menopause.
Well, what is a light period? What is that?
And a good question. And so what is a normal period? So a normal period should be about every 21 to 35 days, lasting approximately 5 days, and bleeding approximately 60 cc's. And they actually measured this in 60 cc's of blood every episode. And so, you know, that's 2 shot glasses.
Two ounces. Yeah, it's about 2 ounces per ounce. So it's about 2 ounces of blood. Okay, so that is a normal. And what about, is there any role for cramping or for bloating or the other symptoms? Are they part of a normal light period, or are they associated with the abnormal uterine bleeding?
Yeah, so, you know, cramping is a normal process because your uterus is made to do 2 things. It's made to bleed and have a period and push babies out. And so when the lining of the uterus starts to shed,
and make money for gynecologists.
That's right. That's right. Yeah. And so when the uterine lining bleeds and sheds during menstruation, the uterus is going to cramp a little bit. And the preamble to that is increase in inflammatory molecules that facilitate that allow the uterus to squeeze it out. And so a little bit of cramping is absolutely normal, you know, but but you shouldn't be kind of, in your room in fetal position, popping 800, ibuprofen every couple of hours because it's so uncomfortable. That
makes the bleeding worse, by the way. It's a non-steroidal anti-inflammatory drug. And I've never quite, as a man, I've never quite understood the use of non-steroidals that make you bleed in someone who's got a bleeding problem. But
yes, I know.
Yeah.
One thing affects the other.
So what then is the abnormal uterine bleeding? I know it's been reclassified. Can you go through these? Because most women in their lifetime are going to experience at least one, if not more, of these 4 categories.
That's right. So we can basically classify them as structural and non-structural. So structural causes could be uterine fibroids, endometrial polyps, or inflammation in the lining of the uterus, infection, or even something like cancerous or precancerous. And then the non-structural causes, most of the time, are hormonal ovulatory causes. So things that affect the brain, sending signals to the ovaries that affect regular periods, but can also be from medications that doctors give, to treat, blood clots or pain, non-steroidal. So we call it iatrogenic causes. Some people have heavy bleeding because they have genetic propensities to bleed. And there's a variety of things that, those are, without getting into the weeds, So it's basically structural and non-structural, and the gynecologist's job is to really figure out which one it is. So.
Right. So one is the hormones that are global that regulate the bleeding cycle, and the other one is the blood vessels themselves and the muscles.
That's correct.
And just let's throw in, is endometriosis part of that, or is it a separate component?
Yeah, so that's a really good question. I do classify it as a structural because it's actually a structure that becomes affected within the lining of the uterus. And so they have these categories. It's called AUB, and then the dash is what the etiology is. So we consider endometriosis to be AUBE or AUBA, which is adenomyosis, which is similar to endometriosis, but it's still very structural because it's an aberration of the normal structure of the lining. So,
okay, so endometriosis is an abnormality. It's not just, like, the way I look at it in my profession is acid reflux. When the stomach squeezes, it goes up or down. When the uterus bleeds, it can go backwards or forwards. It's not that simplistic.
Oh yeah, endometriosis is really fun. It's actually like my new topic, and a lot of gynecologists really shy away from endometriosis patients because there has been so much theory about really what causes endometriosis, but the prevailing wisdom right now is what's called Sampson's theory of retrograde menstruation. So when you bleed not only through the vagina, but through the fallopian tubes, which is normal. But then what we're knowing is that there is gut inflammation from gut microbiome dysbiosis, or just changes in the collection of protective bacteria in particularly the small intestine, that lead to leakage of inflammatory molecules into the peritoneal cavity. So basically the lining of our pelvis, and then that causes inflammation. When the endometrial cells leak through the fallopian tubes, they stick to those inflammatory areas and then do something called neovascularize. They actually create a new blood path in between the peritoneal layer and actually allow for and receive the hormonal signals to bleed just like the lining of your uterus would. And where is it? It's the space between the rectum and the uterus, and which is a lot of people, when they have endometriosis, have pain when they have intercourse because the penis is hitting at the back of the vagina. And that's where the sticking of the endometrial cells most of the time, and surgically, is very complex to dissect out. And so endometriosis, I would venture to say, is a gut problem, and not necessarily a function of womanhood. So
I would actually rephrase that slightly. And that is that endometriosis I would put into a pro-inflammatory environment, and the absence of endometriosis is based upon an anti-inflammatory diet. And again, the gut is my home as a surgeon, as a GI surgeon. And what we're dealing with is exactly what you just said. A large part of what we focus on, the use of a ketogenic diet, is to dumb down that pro-inflammatory environment in the gut, in the colon, in the rectum. And what you're dealing with often is fermentation and acidification of the stool. So the things that cause colon cancer, diverticulitis, diverticulosis, all of those are damages in the gut that are also going to promote the growth of abnormal tissue, whether it's in the gut or across the membrane. So there's a lot of synergy across with that, and a confluence of care that should reduce that.
Oh,
so,
yes. It's all bacterial translocation, right? You know, and so absolutely. And we're always talking about, I'm teaching my residents and medical students about that concept all the time. And you're right, it's an inflammatory problem that once you reduce the inflammation, then everything gets better. Everything gets better. So
right. So and again, that's something we can explore on a different day. However, getting into the AUB side of things, I know as a gynecologist, we talked about this a few minutes ago, you have the unique position that you can be both preventive as well as therapeutic. When there's a problem, you cut it out or treat it with medications, but you also interface with people, especially young people, from the age of first starting to get their periods and then maybe having birth control, which are all opportunities to work with them in a preventive way. A question as a pediatric surgeon, we know even in my lifetime that the age of menarche, which is the first time a girl has a period, has reduced dramatically. I mean, when I was in medical school, 13, 14, 15 was not an uncommon time to see someone that hadn't had their period. Now, when I see someone that's 13, 14 years old and they haven't had their period, you got to look and make sure they've got a hole in their hymen, because they could have hydrometrocolpus, which is it's a bizarre situation. We're seeing kids of 8, 9, 10 starting to have their periods. Can you talk a little bit about that? Because that also, to my mind, is part of the abnormal uterine bleeding. When a baby, when a child of 7, 8, 9 or 8, 9 is starting to bleed. Any thoughts on that in the AUB spectrum, in the research that you've done?
Yes, so it's considered what's called AUB-O, so AUB ovulatory, okay? And so really there are several transitions that happen within womanhood that really rely on the concept of adequate nutrition, okay? And so when a woman, particularly a young woman, you know, in the pubertal age, perceives through a variety of mechanisms in the hypothalamus, when there is a careful balance of insulin, leptin, all those factors that start to signal to the brain that it's okay for the hypothalamus to start pulsing something called GnRH. And so once that balance starts to occur, and it's occurring earlier because we're more we have more food basically, and more higher levels of insulin starting earlier and earlier due to this chronic disease that we're living with of obesity and you know, hypercaloric states that activate those factors earlier and earlier. And so a lot of times, a lot of folks will, you know, kind of lead to, oh, well, there's, you know, estrogens in our, you know, chemicals, and that kind of activates, that probably plays a role, but not as much as the hypercaloric state that we're seeing our young people.
I'm going to change at least change my understanding. I don't think it's a hypercaloric state. And I'll tell you why, is because if you eat too much steak, it's not going to happen.
Correct.
I'm going to use a specific word. It's a hyperglycemic state. It's an chronic excessive carbohydrate consumption, both in terms of quantity as well as a fraction of what we're eating.
Yes.
And the hyperinsulinemia is triggered by chronic excessive carbohydrate consumption. So, and I hear what you're saying there. And obviously, as a pediatric surgeon, there's a crossover for me into that realm to a certain extent. So along those lines, take me down the hormonal, since we're talking about the ovulatory side. What is a normal hormonal cycle, and how is it regulated and controlled? Because all of these different hormones, female hormones, as well as metabolic hormones, growth hormones, anti-growth hormones, they all interact because the human body is cyclical in everything it does. Everything works in a hormonal feedback. We call that homeostasis, where one thing goes up, the others come down. And when there's disruption to that, that's a problem. Can you, and I'm going to ask you specifically, what is the normal female? I know this is Gynecology 101, but what is the normal female hormonal cycle, and how does insulin affect, how does it regulate that?
Okay, so this is very important because for thousands of years, millennia, millions of years, as humans, we have been designed to procreate, okay? And so if there is anything that will threaten that ability to procreate, it's going to stop our ability to procreate. And most of the time, that has to do with the hormone insulin and also endothelial inflammation, okay? So when I talk about menstrual cycle to women, if they tell me that their period is every 8 days and 5 days, I know they're functioning well. That is the most beautiful vital sign that I can tell what their metabolic health is. Aberrations of that make me start to think about, is there too much insulin or too much inflammation or both? Okay, too much insulin, irregular period, too much inflammation, heavy period. Okay, and then there's a combination of both. And so what we know, if we bring it to the PCOS, polycystic ovarian syndrome pathogenesis, we know that elevations in, inflammatory adipose tissue, glucose and fructose, and we know, and also elevations in insulin will directly affect the ovary. And the luteal cells of the ovary will start to produce more testosterone or androgen.
Andrea, can I stop you for 1 second? Because there is a physiologic pathway. So can you take me, not all the names, because there's 21 of them involved, but can you take me, and this is what a lot of people don't understand, is every hormone you've just talked about, well, not the LH and the FSH, but every one of the steroid hormones, the estrogen, progesterone, testosterone, they are all start with a common precursor, and most people don't know this. The common precursor is something most people have never heard of before. It's called cholesterol.
Yep.
Called cholesterol. So everything starts out, all the steroid hormones, including adrenaline, noradrenaline, they all start out. Vitamin D is not even a vitamin. It's a steroid hormone. And it starts out as cholesterol. Can you take me down the pathway, not the individual names, but where you get progesterone, where you get estrogen, where you get testosterone in a female? Yes, testosterone is present in females. And how perhaps insulin can redirect that, and where the sex hormone binding globulins, how does all of that play a role? Because so many gynecologists and now PCPs are testing these various hormones. How does that pathway work? And then based on that pathway, let's talk about PCOS and some of the other dysfunctional diseases.
Right. So we can take it very granularly. So the ovary there's lots of little different cells within the ovary. And so they're called the theca-lutein cells and then the granulosa cells. And the granulosa cells are what produces estradiol. And the theca-lutein cells will also produce testosterone and progesterone, depending on what phase of the menstrual cycle. Okay. So there is some estrogen, and it's called in the form of estrone, that's produced in the adipose tissue that does have estrogenic effect, of course, to the lining of the uterus and can change some of these parameters. But yes, and so it really just depends on the phase of the menstrual cycle. And I actually have a menstrual cycle video through the Nutrition Network and the Women's Health Elective if you want to look at the granular details, because it really does just change on per day. And so, but if you talk about where those hormones come from, you're right. Cholesterol, absolutely. And then cholesterol will change, and there's a huge pathway that we can talk about, but it's very much related to the ovary, what phase in the ovulatory cycle, and a lot of the surrounding adipose tissue that play a role. Okay, and so when you bring it to PCOS, well, the elevations in insulin will affect the ovary and cause it to produce more androgens, and that androgenic effect will obviously affect our circulatory system and hit the liver to produce what's called less of sex hormone binding globulin. That sex hormone binding globulin does exactly that. It attaches to the free circulating hormones of estrogen, testosterone through our body. But if there's less of it, there's more testosterone and estrogen to do its effect. And then that's where people see a lot of the acanthosis nigricans, the darkening of their necks, skin tags, acne, extra hair. But then what happens is that extra circulating hormone, testosterone and estrogen, affects GnRH in our hypothalamus. And gonadotropin releasing hormone, GnRH, which is not something that we test for because it changes on a second-to-second basis, affects the anterior pituitary and something called luteinizing hormone and follicle stimulating hormone. And it changes the ratios that are the signals to the ovary to ovulate. And if it doesn't signal in a pulsatile fashion the way it should, then ovulation stops. And so what I tell folks is, what's the treatment? Well, the treatment is to reduce insulin level, because that's what caused all those cascades that lead to the problems with ovulation in the hypothalamus in the first place. And so while birth control and metformin and all those other medications really do help your body use insulin a little better, it helps your body increase its sex hormone binding globulin with the hormonal contraceptives that we take, it doesn't get to the root of the problem. And the root of the problem is really reduction in inflammation, reduction in insulin.
So yeah, and I think a couple of the other numbers that we look at a fair amount, and certainly in the work that we do, there's a lot of crossover. We look at, I don't measure pregnenolone very often, but pregnenolone is a common precursor, if I'm correct, in the steroid hormone pathway. And insulin, elevated levels of insulin, affects which way that is going to go down the steroid hormone synthesis pathway, toward testosterone with high levels of insulin, toward estrogen, progesterone. We'll talk about that in a second. Tell me about DHEA and DHEA sulfate, because that's something we check quite a bit.
Oh, yes. And, I think a lot of people talk about, when ladies have, extra testosterone too, in gynecology, we always want to make sure that we're not missing like congenital adrenal hyperplasia and stuff. And so that's a really rare phenomenon that are associated with like huge elevations in DHEA and stuff. But, I don't necessarily do a lot of DHEAS checking. I probably should, other than when I'm looking at a patient who has really starkly elevated testosterone levels. But clinically, I don't get a lot of information, out of it, because there's just such nuance that comes to it that it doesn't affect clinically, because really my North Star is insulin. And, but yeah, the textbook will tell you to check it. There is a role for it, but I don't do it all the time.
It's interesting, in my PCOS patients, DHEAS is almost always elevated together with testosterone, and we can track DHEAS levels and see it come down as they resolve some of the PCOS, even well before testosterone. And I look at the free as well as the total, but before that free testosterone level comes down. My very last patient I just saw was a 21-year-old woman who had a testosterone level of 18.5.
Oh, okay.
So it's just like, okay, that just blows your mind a little bit when you're seeing this kind of thing. So we tend to track that and then work with them. But I always met, and you, I assume, also, unusually for a gynecologist, we'll look at insulin levels and we'll look at perhaps C-peptide, A1C. Are those markers that you use more commonly than some of your colleagues?
Oh, yes. And I have to remind them several times that even American College of OBGYNs recommends that we check that, but it's just so easy for some folks to check hemoglobin A1C, but even as way precursor to that is to look at what is really happening with insulin, and then C-peptide, which is, the substrate, from proinsulin. And so once we look at those numbers, it's very telling to what's really happening, because then you can kind of look at where they are in the Kraft model and, and look at, have you burned out all your insulin stores? What's your beta cell functioning like? And so absolutely, insulin's my North Star. The most interesting patient is, though, the one that has really low, insulin and really low hemoglobin A1C. That's like this new group of people that I'm finding that still have regular periods, but their periods are crazy painful. And I do the same thing. I'm like, well, initially in my understanding of this, I'd say, well, you're doing okay, but now and more as I'm learning, I'm like, wow, that's too low. Your insulin level's too low. What's going on? And still putting them on a low carb diet does help them tremendously with reduction of that inflammation. And then those insulin levels actually end up normalizing, which is really interesting too. So.
Right. That population, and we see it in a few different spectrums. Number one, the commonest group of women that I see in that are my LMHRs, my lean mass hyperresponders that are already on a carnivore diet, and they've corrected insulin sensitivity and they're now insulin suppressed. That's the one group. The other group are the type 1 diabetics, which is a different category. And then we also see well, I guess that's the most important common group. I forgot what I was going to say there, but the LMHRs is a group of people that we see that, and they're not triggering insulin because they're so deep ketosis, and that does affect hormonal generation. So, but I want to put, that's kind of more maverick thing. When we talk about PCOS, what you're talking about, correct me if I'm incorrect, and I'm going to throw things out, and I'm looking for your expertise to help me with this, is typically what we see the marker is super high levels of insulin and elevated levels of testosterone. Is that a reasonable combination with the PCOS population?
I think it would be super high levels of insulin, but not even really that high. Like I'm talking like 11, 12, you know, and testosterone levels, I look at, I run them, but I look at more clinically, because you can be fooled, and testosterone level is helpful somewhat, because when you have a patient who comes in with acne and, you know, acanthosis and hidradenitis, and you tell them their testosterone level is normal, like they wouldn't believe you. They feel totally demoralized about that. And so, so clinically, I think it helps, but I'm also looking for an androgen secreting tumor. So I run it just so that I'm not missing that. And then if it's normal, or, you know, but they still have the clinical features, I still think it's PCOS 100%.
So the other interesting comment there, and I think you bring up such a valid point, even though you don't know that you did, is that normal is not normal. And what I mean by that, if you look at the range of what is considered to be a normal free testosterone level, it goes as high as 5. I start to look at, and we've done tens of thousands of this blood work, and anybody with a testosterone level over the above 1.5, I start asking that question. Are they in PCOS territory? Then the clinical stuff comes in. But my threshold is a testosterone level of 1. And as we treat that therapeutically with a low carbohydrate diet, we see that come down. When that comes down, I talk to them about, hey, it's time to get on some birth control if you don't want to bump. But be that as it, so our normal tables are vastly different. A normal insulin for me is 6 or lower, not 24 that they talk about.
Yeah.
So, you know, they're going to people out, oh, your insulin's 16, that's fine. And especially if your A1C is normal, well, the reason A1C is normal is because you can produce so much insulin. So the hyperinsulinemic, normoglycemic, a slightly elevated testosterone level, that for me is predictive of the PCOS spectrum.
Yes.
If that makes sense.
Well, then there is the sort of normal insulin level with the elevated A1C, right?
That's a different category, though. So that's
what happens to them when they've been PCOS for so long, and then they start to get normal periods back, which is what happens when ladies get older, okay? And so because they've burned out their insulin stores so much that they're actually getting lower, and then that lower insulin will activate the normal cycle again.
Well, okay, so the way I represent that is everybody, when they eat excessive carbohydrates at first, is going to see an increase in insulin because they become progressively insulin resistant. And this is where the genetics comes in. Some people genetically can produce massive amounts of insulin, okay? But everybody has a cap at which, depending on the insulin resistance, they can produce a maximum amount of insulin. And for everybody, that's slightly different, but you can do a bell curve of that. So when I do a bell curve of my results, I can see a bimodal bell curve. On one side, you've got your obesogenic people. The women have very high insulin levels, relatively normal blood sugar, relatively mid-range A1C, maybe as high as 5.6, 5.7, but not in the diabetic range. But their testosterone is high, and the estradiol may or may not be low. Some of them have higher progesterone, some of them have higher estrogen, and we'll talk about that in a little bit. But those people are hyperinsulinemic. Their risk of diabetes and their risk of vascular inflammation is low because that comes from the high blood sugars, the endothelial injury. They are suffering the consequences of hyperinsulinemia and disruption of the steroid hormone pathway that way. On the other hand, we've got a group of people who cannot produce a lot of insulin. So their insulin numbers are slightly elevated, but not enormous. Their blood sugars and their A1Cs are much higher, and their testosterons are low, but their estrogen and or progesterone is abnormal. And what we look at when we look at the demographics of those people, now I'm being very agricultural about this, those with a higher estrogen level are the fluffy fat people, where they're fat everywhere, they're kind of Eskimo looking or Inuit looking. And then we've got the group with a slightly higher progesterone, maybe a shortened period length. And they are progesterone dominant, and they tend to have lipedema, which is where the weight is all in the lower part of their bodies. And these are observations unreproduced in the literature, but these are observations from our practice. And I tend to separate the two populations out to the hyperinsulinemics and the hyperglycemics. And the hyperglycemics have the vascular side. The hyperinsulinemics also have an inflammatory component, but it's not mediated at an endothelial level, at least at first, but they will cross over. So there may
well, then I separate those women as the hyperglycemics who are going to get fibroids, and then the obesogenics with hyperinsulinemia who are going to get endometrial cancer, endometrial polyps. And so, and there's great data that looks at the increase in visceral adiposity and their relationship with uterine fibroids, and then the peripheral.
When you say visceral adiposity, that's the central, the truncal in the abdomen and the chest. Okay, which is more of the testosterone, the androgenic effect, the male type effect. Okay. So, so that's exactly where I was going, because you've just opened such a beautiful exposition. But if you don't understand what I just talked about, those two genetic patterns, one being where sugar does more damage, the other one where insulin does more damage, and the body's ability to turn sugar into fat protects them from the damage of sugar. Now you're seeing, now let's talk about the gynecologic side. You just said that you are seeing two separate patterns, or two slightly different patterns of disease in the uterus. One is more on the fibroid side, one is more on the muscular part, the smooth muscle changes, and the other one is more on the blood vessel changes. And just remind me again how you associated those two patterns.
Yeah, well, surgically, and honestly, it was the ladies the thinner, leaner ladies in the beginning, in the early 20s and 30s, who started developing disfiguring fibroid uterus. And then you run their A1C, it's like 5.8, 5.9, and you're like, gosh, that's weird. You're so young. Why is this happening already? And then you've got the ladies with really heavy bleeding that sometimes would have polyps, which are levels of markers of inflammation at the glandular level of the lining of the uterus. And then you remove them surgically. And then if those ladies, those obese ladies don't lose their weight, then they will eventually get that hyperinsulinemic and then estrone response because of the peripheral adiposity that they contain, and that stimulates the lining of the uterus to turns it into endometrial cancer later. And so it was fascinating to kind of just see like what's going to happen. And then the third one is when the leaner but more viscerally adipose woman burns out her insulin supply. Okay.
That's the crossover. That's what I call the crossover.
The crossover. And then that woman is morbidly obese with disfiguring fibroids, who sometimes we're seeing also can lead into really unusual cancers gynecologically. And so it's very exciting to start noticing the pattern. The diabesogenic and obesogenic pattern is fascinating to identify, because if clinicians don't see this, and then when you see it, you can't unsee it, right? Then you know exactly how they're going to go, and you can treat them very easily, almost like old medicine, where you can remember the physiology, and then, and not worry about, oh, is this going to work? Is this going to work? No, you know exactly how to treat a patient. It's kind of like the fundamentals of medicine right in front of you by understanding these patterns. So.
Right. And I think that's so useful, because as you said, one is going to get the muscular or the muscle abnormalities, the other one's going to get the vascular. The other place that I look at the same in the fertile women is that the hyperinsulinemics are going to have more lean toward PCOS and infertility, whereas the hyperglycemics are going to get pregnant fairly easily, but the more likely picture is one of gestational diabetes and subsequent type 2 diabetes, and they are somewhat different. Is that the PCOS people, once they do get pregnant, less likely to have the gestational diabetes. And so they'll carry a pregnancy through, whereas the GDs, the gestational diabetes people, have a much higher loss of, they get pregnant fairly easily, but they have a much higher fetal loss because of the diabetes.
And then even way before then, the hyperglycemics will end up with earlier miscarriage. And so they're the ones that are, the habitual aborters, the recurrent pregnancy loss.
Yes. And that's associated with the diabetes side.
That's right, because of the endothelial inflammation and that neovascularization when the conceptus implants, it can't. And these are also the people who cannot get pregnant despite regular periods, because at the level of ovulation and the inflammation of the blood vessels that assist with the ovary to actually ovulate don't function well. And so if you can't ovulate because of the inflammation at the level of the corpus luteum, which is the ovulatory bubble, basically, then you will never have this conceptus because you can't ovulate appropriately, even though you're having a period every month. And that is the endothelial inflammation. So,
and then the other part, and this is what you did so well in your paper, where you correlated those kind of two, and even though it's a single bell curve, they kind of opposite spectrums of each other with kind of a crossover. But the other place that it correlates, which is with a more generally not accepted but known, even though people don't accept it, difference between cardiovascular disease and which is blood vessel disease, which is more the hyperglycemic side, versus the obesogenic part, which and those folks usually have cardiomyocyte. Now, the muscles in the heart are very similar to the muscles in the uterus. They get abnormalities, often where they develop, the muscles become part of the nerve system in the heart. And those folks can often get atrial fibrillations. They get nerve issues, nerve issues, which is going to be similar in the uterus, except the uterus is not turning muscles into nerves. It's growing those populations abnormally. And
you're talking about the electrophysiology.
Exactly right. So it correlates, as you said, the uterus is very, very similar in embryology to the heart and to blood vessels. It's a modified blood vessel. And even though a lot of gynecologists don't accept that yet, it is so patent. And again, when you look at the influence of these hormones, they are predictable both in the heart and in the uterus in a very similar way as to what diseases to look for. So in my patients, my hyperinsulinemic patients, I know that their CAC score, their cardiovascular risk is going to be low.
Normal.
Glycemics, the diabetic type folks, they're going to have that higher vascular risk.
Yes. Same thing. I know that when I do an ultrasound on a lady who's morbidly obese, her uterus is going to be normal. I know it. And that's very frustrating for them because they're like, well, then what's bleeding? And I'm like, it's so much more complex than that, and those are the ladies eventually who, when I see them, when they're in much more mature age, they have heart failure, they've got lots of, conductive, palpitations, those kinds of, pathologies. And the ones that end up getting the uterine fibroids are the ones that end up getting diabetes way earlier than the other population. So
absolutely. So I mean, it's so lovely to see in your specialty, to see the synergy of this, because while the human body is very complex, it follows some simple trends once you understand that physiologic pathway. So let's talk a little bit about preventive therapeutic strategies. So, and we'll take each of those two scenarios. You get somebody coming in who's still young, who has early evidence of disease, kind of preventive, but I'm starting to see that over the horizon, you're going to get fibroids, you're going to have these endometrial polyps, you're going to have some of these hormonal dysfunctions. How do you intervene? And let's start first with the medical interventions for these folks. And there's some new things on the horizon that I'd love to discuss with you. So I'm not sure the gynecologists have brought into this yet.
Yes. So when I have a consultation with my patients, whatever reason they're coming, endometriosis, infertility, bleeding problems, I always really kind of lay it down in terms of what are your inflammatory triggers, and what are the agents of hyperinsulinemia for you? And then we basically do it as a lifestyle, medical, and surgical approach, and we offer all three. Now, I don't have any data to support that ketogenic diet are going to dissolve fibroids. I have no data with that. I do have a personal
That's reversal. Any thoughts on prevention?
But on prevention, really you can bring those concepts of reduction of cardiovascular disease risk into the uterus. You reduce your processed food intake, you reduce carbohydrates, you increase healthy fats, you support cholesterol, so your poor little liver does only 30% of it, so that you really help improve the building blocks that are available. I do a lot of DHA, like supplementation, and vitamin D and stuff.
That's
and then there's
oil, that's fish oil, the 3 omega fatty acids.
That's right.
Yes.
And then, magnesium oxide also, but then also medications. Some folks are on, unfortunately, federally funded food benefits and stuff, and they just can't, do a lot of those like other nutrition-based therapies because of the current situation that they're in. When that's the role for medication. The medications really do help. And so, for people who have PCOS or irregular bleeding, birth control pills, or any exogenous.
And what when you say birth control pills, because this is a hot topic with us, what are the essentials of the hormones in that birth control? What level and what combination do you like for the different patients, or does it matter?
Yeah, it really just depends on what they're looking for, and so we really do want people to be on some sort of a dual therapy of estrogen and progesterone like therapies. Now, a lot of people use progesterone only therapies because if a woman still has her ovaries, she does have estrogen. But we need a combination of both to protect the lining of the uterus from uterine cancer later. And that's a whole other story. But any exogenous hormone will increase sex hormone binding globulin to reduce a lot of the effects that we see in the PCOS spectrum. And so, but you can also use medications, like inositol, which is like a really great, insulin sensitizer. There's metformin, which is very sort of well tolerated depending on the patient, and, I know what you're getting to is like the GLPs, and that's a really great place. And I do.
Are you using the GLP?
I am.
Them as and who would you who would you use GLP-1 agonists on?
Well, anyone whose insurance will cover it.
but let's move to Canada, where everybody can get anything they want within reason.
Within reason.
Where the insurance company is not the roadblock. But in gynecology, if you had free access to the GLP-1s, what is your indication to use them?
I feel like it's for folks where nutrition-based therapies are only one piece of the puzzle. So if they are not able to really improve their strategy of, carbohydrate restriction, if there are other factors in place like food addiction, processed food addictions, or they just need to see a goal. They just need to lose a little bit of weight. There is such excellent use for them to really help people get to the place that they're looking for. Now, I use it personally as a last resort when folks are struggling with food addictions and things, because a lot of times women come to me and they're looking to conceive. Okay. And then once they cannot be on GLPs when they're pregnant. You just can't.
Why not? Why not?
Yeah, they're currently contraindicated. We just don't have any good studies. And
so the point exactly right. So for example, GLP-1s are contraindicated in type 1 diabetes. I put all my type 1s on GLP-1s and they do magnificently well. So all because, and as a pediatric surgeon, we often see children, it's okay if over the age of 18, but
that's right.
It's not that they're bad. We just don't know. We
just don't know.
We haven't done the studies. So the question I have about GLP-1s in pregnancy is, are they harmful, or do we not have data to support their benefit?
Yeah, we just don't have the data. We just don't have the data yet. So as I understand the mechanism of action, I don't see how they would be. However, we just don't have the data, and we're constantly learning. And I am very minimalistic when it comes to medication introduction in pregnancy. I'm very minimalistic because we really don't know about a lot of these effects that's happening at the neurophysiologic level of the developing fetus. We just don't know, and that's where a lot of Robert Lustig's work comes into play of how insulin resistance, even starting at the fetal age, is coming out, and what we're seeing, and a lot of the inflammatory effects that can lead to neurological disorders later. I just try not to do it, and just because we really don't know, not to say that it's not healthy or safe, or we just don't know. And I'm very, very, I give pregnancy so much dignity, and because of the fact that we don't know so much, and the effects are so great, that what we can do as providers and exposure to the fetus, like, I don't even want to go there, so.
And I listen, I respect that completely. I've not had the opportunity to use them in pregnancy. I am very comfortable with their safety profile. And to my mind, and again, this is an experiment that is going to be difficult to do, but I think should be done, is at least to see if they're safe. Because I can tell you what's not safe is the percentage of women that have gestational diabetes or insulin resistance during pregnancy, the 7-fold increase of fetal loss. Right. Especially if you've got gestational diabetes under 25 weeks, the massive increase. And I've just written a book chapter in the book Ketogenics on this, of autism spectrum disorders and white matter brain dysfunction in these babies that is irreversible. So that population is, at what stage do we do something about?
That's right. That's right.
And so we've got a medication that has been unproven, but has been proven in everybody else to be dramatically effective. And then the other part is there's so many people using these medications, and when somebody is not planned, when a pregnancy is unplanned, and this may be a study to do, when a pregnancy is unplanned, at what stage does the woman typically find out or know that she's pregnant? How many weeks goes by before a woman knows that she's pregnant?
Everyone's different. You would, because if you're talking about the woman who has irregular periods and they have a gap in their menstrual cycle, to them, that's just another month in the year, But most of the people who have regular monthly periods will know at the first week. They're at week 5, week 6.
So typically 6 weeks or so is the earliest that a woman who's not testing will find out that she's pregnant. Is that correct?
Approximately.
Right. So let's say that woman is on a GLP-1 agonist. You now have, and there's going to be plenty of them for two reasons. Number one, a lot of the women who are in that productive age where they're looking to lose weight for social reasons. Here in Palm Beach County, it's a sad indictment, but nobody has natural breasts anymore, and nobody's not on a GLP-1 to lose 10 pounds. It's just cosmetic aspect of that. And I will leave the politics to a different story, but there's going to be a large population of women, and it'll be very interesting just to study those women who find out that they're pregnant and they're using a GLP-1. So that'll be that's already happening. We know it because the other group of women that are going to be, the other way that GLP-1s affect you, because they affect insulin resistance, is you're more likely to get pregnant in an unplanned way if you're treating your insulin resistance. Because insulin resistance is a form of, it's the commonest form of infertility,
of female infertility related to the ovary.
So those women are more likely to get pregnant, and also more likely to not know that they're pregnant for a decent while. So it may be very useful to do an anecdotal review of, and if anybody's watching this and they've had a personal experience with being on a GLP-1 agonist, an Ozempic or a Trulicity or a Mounjaro or a Wegovy for weight loss or for treatment of insulin resistance, and they got pregnant, I'd love to, over the course of time, know how that pregnancy went. Because currently the modalities, so we use metformin, and then what's the next line of intervention in gestational diabetes?
Oh yes, insulin. Absolutely. Insulin.
Which is the purpose of GLP-1, which is a natural hormone, and all we're doing is we're accelerating it and preventing its breakdown. It triggers insulin release. So now you're putting these women on insulin because of their gestational diabetes. Surely something in the lower down on that spectrum that is an augmentation of a natural hormone, which you're doing anyway by giving them exogenous insulin. And when you give them exogenous insulin, you're defying the normal hormonal storage utilization mold because their insulin levels are permanently up. So you're actually creating hyperinsulinemia when you give people insulin.
Yes, you
Again,
sure
I
are.
mean, it boggles
Oh
my
yeah, and
mind
it's very
how.
similar to the thought behind, why, with metformin and the use and the gradual use that ended up being now more standard of care use. It's still off label, but it is still, something that we utilize all the time. And so it'd be very interesting to see how the GLP-1 agonists play a role for exactly the physiologic reasons you described. So.
Yeah,
Okay, Rob, I've got like 5 more minutes before the kids run in. So
okay, but I think that therapeutic approach is so important, especially on the prevention side. And the earlier we can intervene, understanding this and intervening, I think you'd be in agreement with the insulin, with the hyperinsulinemic, hyperglycemic side of things, with dietary intervention, with medication. That is the best way to prevent these diseases. So once you've had once you have these problems, as a gynecologist, what is your approach and what would you recommend to women? Because there's a lot of somewhat emotive, somewhat medical reasons whether or not somebody should have a hysterectomy, a fibroid reduction. What is your thinking in terms of therapeutics?
yes, and so it really just depends on what the patient's needs are and what their current medical state is. And so, if they're coming to me with PCOS, sequelae, then we go down the path of, lifestyle and as always the first, and then, medications, as needed. If we're talking about ladies who have, heavy menstrual bleeding related to uterine fibroids, you can talk about, a lot of the same lifestyle and, medical cardiovascular disease improvements, but we don't really have studies that show that therapeutic carbohydrate restriction will treat and, reduce the size and the burden of uterine fibroids. We don't have that. We do see a lot of really great evidence that is supporting that endometriosis symptoms are improved with, PCOS style diets, as well as, addition of like 3 omegas. But, we don't have anything for fibroids, which is really what I'm kind of hoping to do, and so, anecdotally, I had this 8-centimeter fibroid myself, see the thin PCOS person, and that is gone. And I don't know how to explain that because that resolution even happened way before I came into this space, but the interesting thing is that there's so much room for intervention, but also learning about where cardiovascular disease risk plays a role, because a lot of women do need surgical options. A lot of women do need their hysterectomy, to remove a fibroid uterus, or they're bleeding because they're in the emergency department 3 or 4 times a week, needing a blood transfusion, and it just becomes so burdensome. It's no way to live, and so at that point, you must kind of offer that. It's our ethical duty to offer it. However, you also have to explain to them how they got there, because us gynecologists are really great surgically, but if we don't teach them how they got there and not say, oh, it's because of your genes, that is such a small risk factor in terms of the whole disease, phenotypic expression of what happens to a woman when they develop uterine fibroids or problems with bleeding. And so medical, lifestyle, surgical, absolutely depends on who's in front of you. But you must tell them how they got there ethically.
I think the other key thing that you just brought up that was a light bulb that went off in my head is that women will tend to develop abnormal uterine bleeding, fibroids or bleeding issues, probably about a decade earlier than they are going to develop exactly the same disease expressed in a different way in other more important organs. And I don't mean that the uterus is not important, but you can live without your uterus. You can't live without your heart.
Right.
And if this uterine pathology that we've just talked about is a precursor of cardiovascular disease, having that conversation about, okay, we're going to take your uterus out, or we're going to operate on you for uterine disease, but it's a precursor to this, just like gestational diabetes is typically a precursor to full-blown type 2 diabetes 5 to 10 years down the road. There's almost an obligation to have that conversation, because if you can prevent or reduce the risk of that heart attack, that stroke, that cardiovascular disease that is far more devastating down the road, that's part of the conversation. And clearly, thinking about a hysterectomy, thinking about uterine surgery is a very big red flag for most women because it's life altering in terms of that woman. So the next question is, when you do for abnormal uterine bleeding, let's say you're going to do a surgical intervention from ablation to full hysterectomy, what is the approach that you use, trying to be as minimalistic or maximalistic? What is your decision making?
Well, the first, when a lady has that much effect on their life that a medical and surgical intervention is necessary, it's usually because at that point they've already failed some sort of lifestyle intervention for now. Okay. And then once a patient, it does not properly receive effect of like a hormonal therapy, an oral contraceptive, progesterone therapy to help reduce their bleeding, once they failed that treatment, the next step is in some sort of surgical intervention. And so sometimes, with ultrasound, it'll show us whether there's like a fibroid, but sometimes there will be nothing in the lining of the uterus. And so a hysteroscopic evaluation to look inside the lining of the uterus to find a polyp, to find a fibroid, or even do a dilation and curettage to sample the lining of the uterus to make sure we're not missing anything cancerous is very, very important. And so once we do that, and sometimes that's all you need, that sometimes that level of exploration, surgical exploration, is very important before you really move on to the next stuff of, hysterectomy and stuff. But ablative techniques are very helpful. I personally don't do them in my practice because it's very, very difficult to sample the lining of the uterus to make sure you're not missing uterine cancer in the future, because a lot of these ladies will have heavy bleeding, and it's only indicated for people with regular heavy periods, not irregular periods. And so once you ablate the lining of the uterus, that's it.
That's a very interesting comment, Andrew, because I see a lot of women, and I'm just seeing them on the other side, who've had ablations, and it's here in our part of the world, it's a very, very common procedure, and that was a very cool explanation that you just gave there. So after you've done a DNC, and clearly in the political environment right now, maybe not in California, but in other states, that becomes a controversial procedure in the current political situation with regards to terminations and that kind of thing. I'm not going to go down that pathway. Okay, so if we're not going to do a DNC, or if that fails, what is your next algorithm for taking care of the uterus?
Yeah, so then, it really depends on what a patient is looking for. So some patients are unhealthy that they can't even go through a hysterectomy procedure because of various risk factors on top of that. So there are, embolization procedures that will block off the blood supply to the uterus, that will shrink the fibroids. There's also radiofrequency procedures where we actually, under laparoscopy, put a probe into the fibroids and kind of ablate the fibroids. And then there's surgical procedures where we actually core out fibroids from the uterus. And then there's hysterectomy, procedures where we take out the uterine corpus, the body of the uterus, as well as the cervix, but most of the time leave the ovaries. So,
and okay, so just one question here, and I know there's a timeline, so whenever you're ready to go, we can. But am I correct in thinking that a fibroid is a single cell?
It sort of is.
I mean, in other words, if you do the genetics on that cell, is it a clone of the same cell, or is it multiple cells that are growing?
So it is a hyperproliferation of a single progenitor myocyte that, through different inflammatory cascades, as well as hormonal and vascular influences, create a conglomerate, a hyperproliferation, and a world-like effect of cells that lead to kind of like a cystic property within the uterus. And so it starts with one cell, and then it leads to a proliferation of the nearby cells in order to create a fibroid.
And one of the things that we've seen is in other, and I don't want to use the word cancer with fibroid, but in other cellular regenerative disorders, which are not malignant, insulin has a significant role to play. And we see that in multiple tissues elsewhere in the human body. So at what stage do you say local intervention is not good enough, I need to do a hysterectomy?
Yes, it really depends on how the patient is responding to treatment. And so if they, let's say a patient has, heavy, painful, regular periods, and we put sometimes due to a fibroid, sometimes due to just inflammation at the lining of the uterus from endometriosis, and we put them on a hormonal therapy. And if they are breaking through that hormonal therapy, they're continuing to have heavy bleeding, then we talk about the more invasive procedures beyond that. But sometimes if they just need to be on medical therapy for just a short amount of time, because then they start to improve their risk factors. And I've de-prescribed those medications all the time for ladies who kind of hear the message of reducing inflammation cascade, hyperinsulinemia, and they do great. And so it really just depends on where they are in the spectrum and where how their body can repair themselves, because most of the time they can. It just depends on how grave the disease is. So.
And when you do a hysterectomy, let's take you down that pathway. Two questions. Number one, cervical sparing, or do you take the cervix? And what are the pros and cons? And number two is, what about the ovaries?
Yeah, so it depends. I think that taking the cervix is important because it also reduces the risk for cervical cancer. There are some literature reports of patients who describe decreased sexual functioning after removal of the cervix. The only challenge about leaving the cervix is that oftentimes it results in having to use certain types of resective techniques to remove the uterus from the abdomen that are also associated with increased risk of spreading cancer, God forbid if there is one. They call them morselization techniques. And so feasibly, surgically, it's a lot easier to take the cervix and the uterus, through the vagina. Leaving the cervix puts people at risk for still being able to have cervical cancer, and that surgery just to remove the cervix is exceedingly difficult, and puts people at risk for organ damage on top of the regular risks of surgery.
So what are the reasons for leaving a cervix?
Yeah, so some people would like to have that because they've heard from a lot of anecdotal reporting that it will reduce their risk for less problems with sexual functioning, but also it'll help elevate their vaginal apex and prevent pelvic organ prolapse, which is very helpful also. And there's certain surgical procedures that will help lift the cervix and lift the vagina.
And that's really the question I see. I see a lot of problems with urinary issues, urgent stress incontinence. I know they're very different diseases, but is there an association with total hysterectomy and the risk of that urethral prolapse that then requires a sling procedure down the road?
There is a small risk, yes, there is, and but also menopause also increases that risk too. And so because of the decrease in the estrogen, that helps also support the vagina also. So most of the time when we perform hysterectomy procedures, we do keep that in mind to make sure that the vaginal apex stays elevated. But some folks, their tissue is really just different, and we call it poor protoplasm, where eventually, it won't, be as strong as it used to be, regardless of whether you had a hysterectomy or not. So.
Okay, because that I see in our practice, that is an incredibly unspoken of debilitating feature.
It sure is. It definitely affects quality of life.
Socially debilitating is the loss of urinary function, loss of urinary control. And then what about the ovaries? Take them or leave them?
It depends. Now, certainly, if you have a patient who has a family history of ovarian cancer or breast cancer related to certain gene expressions, then yes, we do recommend it. The lifetime risk of ovarian cancer is 1 in 70 if you don't have a family history, and which is 1.7%. So it's not too high. We do know that leaving ovaries in situ does help reduce the risk of of cardiovascular disease later. And so, which of course has a lot more risk to the woman as she progresses through their life, even heart disease being the #1 reason why women pass away. And so that being said, it's very protective to keep the ovaries, but some people come from families where there is serious concern that, we do know that it slightly elevates the risk for cardiovascular disease later.
And HRT afterwards, hormonal replacement therapy after hysterectomy, with or without ovaries being removed. What is the role of hormonal replacement therapy in this population with the insulin resistance problems?
So certainly when ladies have a hysterectomy, if they're premenopausal and without risk factors for ovarian cancer, we really are going to try to recommend that a woman maintain her, ovaries, because surgical menopause, even if you do supplement with hormone replacement therapy, is not the same as, what we make in vivo. And so it does still is associated with a higher risk of cardiovascular disease outcomes than, if you remove them and versus, keeping them in place versus, replacing, externally. And so if you're premenopausal, we're really going to try to help guide you down the path to keep them, because it's just, we want you to go through natural menopause, but, if you supplemented, absolutely, if you're in the, perimenopause time, which many women are, and supplementing with hormone replacement therapy until natural menopause, which is about age 51, is very helpful in reducing that risk too. And then it comes to the question of, well, should I continue my hormones after? And really, I think that if ladies don't have, contraindications, smoking, blood clots, breast cancer, heart attack, stroke, then, continuing them is a really great thing the earlier that you start, because the Women's Health Initiative came out, and these were looking at ladies like in their 60s who were on estrogen and or progesterone. And that really did increase their risk for all the scary things that we talk about: heart attack, stroke, breast cancer. But when you start at that age, the estrogen receptor changes that have occurred when your body starts to redistribute its adiposity from what we call peripheral or like hip and gluteal adiposity to abdominal adiposity, it becomes more inflammatory, and and that increases as you get older. It has to do with insulin. And so when those ladies who are much older in their 60s, that shift has already happened. And so then when you add estrogen to that, it really does increase their cardiovascular disease risk, which is what we saw in the WHI. But the earlier you start, the better. And that actually reduces that risk of that shift from happening from, peripheral adiposity to abdominal adiposity, which the peripheral adiposity is kind of how those estrogen receptors are in the peripheral tissues are a lot more protective for cardiovascular disease than the visceral inflammatory adiposity. So,
and are you cyclical in that? Are you using estrogen dominance, progesterone dominance, and also what about testosterone supplement?
Yeah, so with estrogen, if we've removed your uterus, then the recommendation is to just give estrogen. And so, but if you do have a uterus maintained within the menopause state, it's a really good idea to give both dual therapy, estrogen, progesterone, to protect the lining of the uterus from too much estrogen that will stimulate the lining of the uterus to turn into something precancerous later. And so testosterone, there are some folks that kind of think testosterone is a good idea in terms of libido and things, but testosterone turns into estrogen. And so then that turns into extra estrogen into the lining of the uterus. And so the recommendation is really not to give it longer than 6 months. And so I'd hate to give something to someone and then just take it away after 6 months. And so I don't really give a lot of testosterone and for those reasons, but it can be pretty dangerous if you give too much. So
here in my setting where I see this peripherally, I just see patients coming in on this. I've seen a very high level of peri and postmenopausal women on very high doses of testosterone.
Yes.
And that has always raised question marks in the back of my head. And I was think about that. What about the woman who has a hysterectomy or goes through menopause, and we see people with completely flat libido? What would you use under those circumstances?
Yeah, so I think estrogen is really helpful with those women because, oh, here comes the kids. Hold on.
Okay, that's okay.
Hi. We'll restart that question in a minute.
Yes.
Hold on a second. Hi, guys. Hi. I'm on a podcast. Just give me a kiss.
We'll cut that out, but just a 10-second or 30-second coverage of libido, because I get that question on a daily basis.
Oh yeah. So, and I just love this question about estrogen and libido, because whether you're on birth control or you're not having periods anymore, birth control really does, hormonal birth control, that is, really does inhibit ovulation. Okay. And ovulation is really kind of like what makes women feel like a woman. It gives them their interest in sex. It rises their estrogen levels and stuff. It creates the pheromone release, makes your partner interested. But birth control, hormonal birth control blocks that. And so, of course, like you're going to not have that interest because you're not going to have those rises and flows of estrogen spiking during ovulation. And so, unfortunately, it kind of happens also when you go through menopause because you're not ovulating anymore, you know. So there's a lot of really great data to support that estrogen really helps that libido piece, you know. But unfortunately, you know, when we look at FDA and what's approved and not approved and stuff, using estrogen hormonal replacement therapy for anything other than what's called vasomotor symptoms of menopause is not part of the indications. Now there's off-label uses and that's okay. You just have to tell patients about that, you know, but, you know, for sure, that happens.
You use estrogen as because I see a lot of the reasons why these women are on testosterone is for libidinal issues. And I've always raised a question mark about that. I know that there was a famous case of a gynecologist in Jacksonville who was prescribing super doses of testosterone and then taking advantage of those women when they came into his practice. And he was arrested and he's currently doing time. So, you know, again, that's the anecdote, but I see a lot of testosterone use for libidinal purposes, and it doesn't sound like that is something that you're comfortable with.
Yeah, it's just not something that is recommended in the long term. And so, you know, I don't want to give folks a little dose of something that I know that after a while we're going to have to stop. I just don't think it's fair to patients to do that. So
okay, so that this has just been a phenomenal discussion. I'm going to have to go back through it and listen and watch it and break it down. I know it's fairly high science stuff that you and I are fairly comfortable with. I'll be breaking this down and trying to segment it a little bit and help people to understand this, but this is groundbreaking stuff. And I think that over the next decade, more and more of this information is going to become more mainstream as our comfort level grows. And, you know, part of what I notice, and this is an interesting phenomenon because I've had to go through this myself, is you've got this duality of understanding where the science is growing away from the convention and yet being trapped into not being able to do certain things because they're not part of the convention. And it's a real difficult ethical dilemma in that we know that there's a certain therapeutic pathway that physiologically benefits us because we understand, or benefits our patients because we understand it, but we can't go down that pathway. We are leery about it because we don't want to be judged conventionally, especially in an academic environment. And Asima's dealt with that, as I've just mentioned. It's something that you're encountering as well. So it'll be very interesting to see how this all evolves. And the sad part is that because our patients have greater and greater access to brown bag hormonal therapy, you know, the Roman type thing that they use in males, and also to these GLP-1 agonists that are primarily indicated for treatment of insulin resistance, but being used and abused for weight loss, we're going to see patients leading this. And the doctors are going to be more conservative than the patients are. And I'm not certain that because then it's off-label use by the patients without direction.
That's right.
That can be because now everybody is getting hold of through the back door of pharmacies of various types or through overseas prescriptions, these GLP-1 agonists, without knowing where it is.
That's right.
So it's going to be the next decade is going to be very, very interesting and illuminating, I believe. Any last comments, any last thoughts or statements in this regard in what you do for a living?
Yeah, no, I just think this is my passion. You know, I think there is so much that we can teach women. And honestly, women don't have to suffer silently, you know, and I think teaching primary care surgeons, OBGYNs, and patients all this information will be so enabling and it'll just we'll just turn into health advocates. And I think if we teach patients with the heart of a teacher, right, you know, then they can decide what they want to do with their health, you know. But I really do believe in teaching patients how their disease pathology has evolved, and then they get to feel empowered by that information. And so that's my concept. That's Conscious Gynecology, you know, and I have a YouTube channel if you want to check it out, Conscious Gynecologist.
We will promote that. We will promote that.
Thank you. And, you know, I think that really, you know, womanhood women are the matriarchs of our families, our societies, our civilizations. And if anything happens to women, truly our social structure will become destabilized. And so honestly, my whole mission is to help empower women with this very simple information, right? Because when it comes down to it, really reducing stress, reducing insulin, reducing inflammation are the hallmarks to really productive and fruitful womanhood. So
I love that. Thank you so much. And this has been absolutely brilliant. I'm going to listen to this again and again to break it down, and you and I will talk. But congratulations on that beautiful manuscript that you wrote. It is phenomenal. It's groundbreaking.
Yes.
And I think it's going to be a decade before people realize and quote that paper as a groundbreaking entry into the world. So
I hope so. Thank you so much. Thank you. Just an honor. So I really love talking to you. So we can go on and on, right?
No, exactly right. And we have way more than I would have, than I know you would have liked. So I appreciate this so much.